Marc Surdyka is back with us. The last time, Mark, you were on was with Stu McGill on all those episodes. How you doing? Any updates since we chatted last?
Nothing big, nothing major. Happy to be here.
Sweet. So the goal today, this was actually a remote client through E3 brought up this idea, and she's a longtime listener to the podcast. And I thought it was a great idea. She mentioned these kind of review and reflection episodes that Mark and I can do where we discuss a handful of prior episodes and big summary takeaways, reflections, maybe things we did or didn't agree with during the conversations. And this is what we're going to experiment with. So if you all like this format of the episode and you find it useful, then we can continue. And if it ends up being no one's interested, then we try other formats. Obviously, we did the debunking series that I think went really well. We brought on other guests. We kind of did that people of the internet. But this one is going to be, let's chunk out a variety of past episodes. Let's dive into it a little bit and then share our own kind of thoughts and summary. So we're going to start with episode 140 and kind of work our way all the way up to one of the more recent episodes as of this recording. We actually, towards the latter half, we are going to kind of reflect on the Stu McGill conversation. So if y'all are interested in actually hearing our thoughts about that, that was episode with, it was just me and Mark kind of giving our thoughts on Stu McGill's conversation with Peter Attia. That was episode 137, which we'll dive into right at the end. And then we're also going to touch on the conversations with Stu himself, 139 and 141 towards the end of this conversation. But let's start at episode 140 and we'll kind of work our way up. This first episode was with Philip Strauff. He is based out of, I believe, Denmark, and pretty much only does research in shoulder-related pathology and conditions and really specializes in frozen shoulder. I thought it was a great episode. He had just published a book called Frozen Shoulder, Present and Future, and that's what we titled the episode. And I think going into it, I had a pretty good baseline and understanding of frozen shoulder itself. But I think for people who have not listened to that episode or who have recent kind of caseload patients with frozen shoulder, I think it was a phenomenal episode where he dives into the diagnosis, the differential, education, treatment options, and what to do moving forward. And then I've started his book, but it's literally like a 300-page book just on frozen shoulder. But people who want to dive more into that, and with any of these episodes, you can go back to them. And also the links are also in those specific episodes. So we're not going to link every single thing from all these episodes in this conversation. But I think the biggest thing for me was looking at frozen shoulder and trying to figure out the diagnostic criteria and how to rule it in and rule it out. And I think the biggest thing that Philip touched on was this passive external rotation component. So if someone's coming in and they present with very limited passive ER, I think he had mentioned 50% or more, that's a significant indicator that it's leading you in the direction of thinking it's frozen shoulder. There's all these other components. You have kind of these age ranges that you would generally think of, more of a middle-aged adult. A lot of times it's more present in females, but I think that passive external rotation lost was the biggest thing that I think is helpful for me to key in on with a patient that I'm evaluating that hasn't had the diagnosis. And I'm going through these other kind of treatment or diagnostic options. So he mentioned, rotator cuff related shoulder pain or rotator cuff tear, shoulder osteoarthritis, these other options where there may be pain in the shoulder or referred in other regions around the shoulder, but there's generally not that much significant passive external rotation lost with any of those other conditions. So I think that's a really big thing like to take home with that conversation. And you can dive more into what are these other things to look at when you're going through the differential, but I think that's a big one to key in on. He had also mentioned if someone had already come in and experimented with a corticosteroid injection and it wasn't providing any symptom relief, he had mentioned that there's kind of a lower likelihood that it's frozen shoulder. Those individuals that have frozen shoulder, it tends to have somewhat of an acute improvement, neither range of motion or symptoms. And then I think the third thing that I wanted to touch on was you don't need imaging to rule in frozen shoulder. So if you are likely suspecting that this is the diagnosis, you don't necessarily have to refer back out for imaging to confirm that suspicion, and you can move forward with care unless there's other things that continue to pop up that either you are concerned that it's something more of a red flag, or you're truly uncertain and you want to get kind of a surgeon's perspective or another provider. I will kind of stop there. And Mark, do you have any thoughts or other things you wanted to add on from that?
Yeah, just to clarify, for that passive external rotation loss, as physios or other healthcare providers, you're looking at external rotation in neutral specifically. So you're looking for that 50% or more. And then you would also be looking for generally like 25% or more in another direction, such as abduction. But yeah, that external rotation is really important for that. And understanding that that stiffness is like a true stiffness, as opposed to, you mentioned these other diagnoses, and perhaps there's limited range of motion, but that is associated with pain. And so it just highlights the importance of being very thorough with your evaluation, making sure that, you know, the patient is able to be relaxed when you're assessing this neutral passive external rotation, so you can get a true positive or a true negative to help you key in on this diagnosis. And then, yeah, as it relates to imaging is usually used to rule out other diagnoses, right? So if somebody got an X-ray, it's maybe to rule out stiffness due to osteoarthritis, as opposed to ruling in frozen shoulder.
Mm-hmm. Yeah, and then I think another big thing towards the second half of the conversation with Philip was just the management strategies. What can we do if we're confident that it is frozen shoulder? And he really highlighted on patient education as being the number one factor. How long does this generally take to resolve or to notice considerable improvement in symptoms? What can you do and what may you not do during this period of increased symptoms, increased stiffness? And the biggest thing he had mentioned was this is just generally a really long course of symptoms. So on average, he had mentioned it takes about a year, year and a half to 2 years for symptoms to fully resolve. But he did provide a big caveat that a lot of individuals presenting with frozen shoulder, they may also have these comorbidities, and taking that into account as the clinician, and then bringing up with the patient that if they have diabetes, if they have these other comorbidities, that may extend the timeline, and having that understanding as well, and providing that education that this may lengthen the total duration of symptoms is something to consider and to keep in mind, and not to assume that if they're presenting and you're seeing them and they've maybe had symptoms for 4 months, if you're treating them for a month or two, it's not surprising now they're 6 months down the road and they still have symptoms. And we're going to go into this again in another episode that we discussed, just Mark and I, on kind of these reactive approaches. But something like frozen shoulder, we wouldn't expect considerable changes session to session because of how long this course of recovery is. So I think that's a really big thing Philip highlighted. And then a big thing as well was pushing to remain physically active. And that's part of the education piece and the treatment piece. He had broken it down and kind of into two pieces of generally remaining physically active. What general physical activities can you do day to day, whether it's walking, household work, gardening, etc., that keeps you generally physically active? And then more locally at the shoulder, what are things kind of site specific that we can continue to work on? And he mentioned there being benefit for slowly chipping away at some active range of motion, some loading of the shoulder in the positions that you can get into, and that may be a little uncomfortable, but aren't, significantly spiking up your symptoms, but things to maintain muscle mass, strength, slowly improve the range of motion of the shoulder. So chunking those two out of one, being as physically active as you can generally, and then at the shoulder itself, still continuing to load it, continuing to slowly look at the range of motion and improve the range of motion over the course of months and or years. The last thing that I'll touch on, and then we can move on, is I asked about surgical options in that episode. And it seems like there's a little bit of uncertainty. Philip had brought up this kind of capsular release that seems to be a little bit more popular now, as opposed to an MUA, manipulation under anesthesia. But he also discussed the UK Frost trial, which I think they mentioned there wasn't really any clinical superiority between just physical therapy, a capsular release, and MUA. I think they were comparing the three, if I recall. So I think there's a little bit of a shoulder shrug on some individuals do really well with capsular release or manipulation under anesthesia, but a lot of times it's not a home run. So that shouldn't be considered an immediate treatment option. Any other thoughts, Mark, with this episode or frozen shoulder in general before we kind of dive into the next one?
Yeah, I think the prognosis is just really important here. And it does go back to the differential diagnosis, because it's going to change a patient's expectations. If a patient comes in, and this is going to happen to every physical therapist, where the patient says that they have frozen shoulder, or maybe you're given a referral from a doctor and it says frozen shoulder, and you're looking at the difference of prognosis and, the time to recovery, and potentially differences of years. So, hey, yeah, you do have frozen shoulder. This is going to take 1.5 to 2 years or longer, or maybe less. And it depends on these other comorbidities and, overall health and lifestyle. Or, hey, actually, this is what we would describe as rotator cuff related shoulder pain, and we might expect this to get better in a few months. So that's really huge. I will also say that I do like that this discussion about comorbidities, maybe diabetes and just other health and lifestyle considerations for frozen shoulder. But I think this is important for pretty much every diagnosis. And it's hard to do one-on-one in a patient setting, but it's why we do it, in our broad educational strategies and podcast episodes and YouTube videos and blogs, is that all of these things are always going to affect healing, right? Smoking status, nutrition, physical activity. And so that's just something to consider for anybody that you see. If somebody's, post-op total knee replacement, but they've been relatively inactive and, they smoke and et cetera, then maybe that timeline that you had in mind is going to be shifted a little bit in one direction, and vice versa. If somebody is extremely healthy and active and fit, maybe that timeline for that prognosis after a surgery or condition is, moved up a little bit. And then the last thing with prognosis is that even though it does take a long time, physical therapy is an important component of that recovery in order to regain, full function of the shoulder. It's just not necessary for a 3 times per week type of strategy when it's such a prolonged process.
Episode 142, we're going to leap over 141 and touch on that at the end with Stu McGill. So 142 with Brady Green, calf muscle strain injuries. Brady was the man. Brady is based out of Australia. He's a researcher and clinician, does a ton of work on calf muscle strain injuries, and that was the entire episode. So he did a very thorough job diving into the examination portion and initial kind of treatment plan of care portion with muscle strain injuries. I think my biggest takeaways were, one, seeing how he flowed through an initial exam, and then his thought of, well, how do I differentiate a soleus versus a gastrocnemius injury? And then also ruling out and making sure that this is not another injury around the lower leg, whether it's, an Achilles rupture, Achilles tendinopathy, a DVT, anything else that you immediately want to rule out. But then more specifically, if you were thinking it is a calf muscle strain, how do you differentiate between a soleus and a gastroc? But I think the way that Brady in the episode flowed through this very logical clinical exam, initially diving into the history and the subjective piece, that provides a lot of information of guiding you what one you think the diagnosis is. And then he had discussed that a lot of these gastrocnemius injuries are more acute mechanisms, and you can almost feel them in the moment, and they're very high energy. And high velocity typically when they occur. Soleus can be a little bit more like insidious in nature. People may not be sure when it initially started. It's been lingering for a while. He said that that's not always the case, but during the history and the discussion portion before the clinical exam, I think keying in on that was really good to know. And then he discussed just this flow of starting with palpation. He says he likes putting them prone, actually kind of working your way up the muscle belly and starting, I think he had mentioned like starting as distally as possible, kind of at the foot, going up through the Achilles, and then working your way medially and laterally along the calf and the medial and lateral gastroc and deeper into the soleus, and just seeing one, if there's any kind of palpable change or the kind of discomfort or tenderness to palpation along there. And then going into just the range of motion along the Achilles or along the ankle, the calf when it's being stretched, the knee range of motion, etc. And then he does a really good job in the episode of listing these force capacity and tolerance tests, starting as simple as a manual muscle test of just, can they tolerate kind of a submaximal isometric contraction as you push against them in a variety of positions, primarily probably plantar flexion if we're looking at soleus or gastroc, and then going into a standing double leg heel raise, and then 2 up, 1 down, a single leg heel raise, double leg hopping, single leg hopping. He mentions that a lot of times you're not going to go all the way through these capacity or tolerance tests, but you're keying in on how much potential disturbance and injury is there locally at the site, and what is your also entry point for care. If they can only handle, some mild isometric contraction, then that's a lot lower of a starting point than someone who can work their way all the way up to double leg hopping, and then they notice some level of symptoms or discrepancy left versus right. So I think that episode, for people who have any of these calf muscle strain injuries on their caseload, or if they want to learn more, going through and listening to the whole thing of that full exam that Brady talks through. And then he, at the end, kind of discusses a return to run assessment, but his criteria was starting the run process. Can someone do, from a body weight strength endurance, can they do at least 20 single leg heel raises? And he does it to a metronome. So he had said 60 beats per minute, but they're standing, legs straight, 60 beats per minute, going up, going down on that metronome. Can they do 20 clean repetitions? And that's somewhat of a standard for starting the run process. And then he had also mentioned kind of these peak force values that I think get a lot harder to measure practically in clinic, but something as simple as, can this person do 20 clean, consistent, even tempo single leg heel raises to start the return to run process? Those were some of my big takeaways and just kind of reflections from the episode. Mark, do you have any general thoughts with calf strain injuries or that topic?
No, but I will say that if you want to see all of this stuff, Tony Camella, another member of E3 Rehab, man behind the curtains, made a really detailed YouTube video based on Brady's research. So it's a nice thing, like you can listen to this podcast episode and hear it from the researcher himself, and then see how Tony translated that and see some of that stuff in practice. So those are 2 good resources that, as Chris said, if you're seeing somebody or you're suspecting of somebody of having these injuries, those resources are there.
Totally. Yeah, that's a great video. And I told Brady that video is out there, and I don't think he realized, but I said Tony used a lot of your research for that video, and he did a great job. Let's go episode 143. This was me and you, Mark, assessing reactive approaches to pain. Do you want to maybe touch on what the goal for that conversation was? And then I can follow it up with my reflections on Louis Gifford's work.
As the title kind of implies, our goal was, as a physical therapist, how are we approaching the experience of pain that patients are presenting with? Whether that's during the initial evaluation or during follow-up visits. Let's say they have shoulder pain, they come in for a follow-up visit, they're in more shoulder pain. What is our response to that? Is it catastrophizing what happened? What can we do? How can we fix it in the moment? Or is it, let's discuss what's going on. Let's come back to our plan. Are we still moving in the direction of that plan? And how can we maybe modify that plan if required? But it's being proactive in our approach rather than reactive. And it's not to say that we are dismissing the patient or not listening to the patient or ignoring the pain. It just means that we're not being so reactive to it in the moment. And you've been posting a lot more on Instagram, which I think is great, and your own reflections and things that you've read and listened to. And you read these 3 books by Louis Gifford, Aches and Pains. And afterwards I was thinking, I was like, man, that would have been really good to have some of those reflections in this podcast episode, because so much of what he says in those books really ties in with what we discussed in that podcast episode. And I know you have some quotes from him. I might have quoted him like once or twice in that podcast episode, but it had been a long time since I read those books, and they're fresh in your head. And like, I know you wrote those quotes down or maybe highlighted them or something.
Yeah, I bought those 3 books, Aches and Pains, The Nerve Root, and Graded Exposure, because of our conversation on that episode. And then I think the week or 2 after that, I had taken a Chris Johnson and Nathan Carlson course, and Chris Johnson had also mentioned Louis Gifford, and the name just kept coming up, so incentivized me to read it. And I was blown away with the books and Louis' work, and I was kind of bummed that I never heard about him prior. I'm curious, Mark, how did you hear about Louis? Was it in grad school, or did you have a clinician talk to you about him?
No, it was probably just a resource that I found online.
Got it.
Early couple of years as a clinician, looking for, maybe it was like pain science or communication or something along those lines, because especially that first book, it's very heavy on neuroscience, but then it's just, he does such a great job at simplifying communication.
Yeah.
And so, if people are open to it, it is, they're a bundle of 3 books, and it takes a while to get through, but they're definitely books that I recommend to others. I don't have my set anymore. I gave it to somebody else to read, and then like hopefully she would pass it on to somebody else, and just goes that way
down the road. Yeah, Louis, I believe he passed away about 10 years ago. I was looking him up right before this episode. I think he passed away in 2014, but he was based out of the UK and was a physio for like 30 years. And these 3 books, it dives into, yes, like Mark mentioned, some of the harder kind of science and physiology on some of the what's going on with pain and other things, but also this kind of like poetic way of stumbling your way through being a physio and the healthcare encounter. In the first book, he talks about his initial patient experience. I think he either went to someone's house or someone's like a patient was like brought to his home. I don't remember the specifics, but essentially these 3 books, it goes through periods of his life as a healthcare provider and very famous individuals that he interacts with from the research world and from physio, and then these patient experiences and his reflections on what is valuable to me as a physical therapist and to patients, and what do I root as kind of my principles of care and treatment. And a lot of the quotes that I pulled from the book, I think highlight what were his big kind of rooting thoughts and reflections throughout his career. I'll read a few of them and maybe we can chat on some of them, and I'll go through the 3 books. So again, Aches and Pains was the first of this 3-parter. Then there was The Nerve Root, and then Graded Exposure. I don't really know if I have a favorite. Maybe Aches and Pains initially, because I didn't have any exposure to his writing. So maybe it like hit the most and it was the most novel. But I love them all. So a few of his quotes from that first book, Aches and Pains, I'll read the first one. And I'm just going to highlight some of the things within the quote. So in my very early naive days as a physiotherapist, I wanted to get into curing and fixing patients' aches and pains. I wanted to be an impressive operator. I wanted to have a good reputation, and I wanted patients to be saying, I walked in doubled up and went out straight, and or such like. I actually believe this was what I would be taught, and if I got good at it, this was what would happen. As time went on, it clearly wasn't that at all. And to be honest, that just wasn't the real me. I'm not a natural show-off, and I don't do bullshit very well either. I changed as I've already described. Knowledge, good rational explanations, and sound evidence-based reasoning were where I was to feel most comfortable. I simply let me be me. We can go through a few more, but even that quote of these initial thoughts of, I want to be this healer, I want to provide this quick, instantaneous relief, that shift into him realizing that's not his personality, that's really not how it goes a lot of times. And what seems simple but is extremely powerful towards the end, what he mentioned was this good rational explanation and discussion with patients, and then sound evidence-based reasoning and using what he understands from the research to guide treatment options and decision making. So I really liked that first quote. Mark, if there's any point with any of these that you want to interject, you can. We may not go through all of these because there are a lot of them. The second quote was very similar. I'll just touch on some of it. Quote, the delusion of fix was masked by the instantaneous improvement in range of motion, in range and pain that came with the instantaneous testing we did. A few sentences later, he said, pain can be made to fluctuate quite dramatically for short periods, but that miraculous sudden pain cures for these type of conditions just do not occur. And that, I think, is very salient to that discussion we had on these reactive approaches to pain, where it's very easy to get short-term changes in acute range of motion improvements, acute symptom modification, and that's kind of a mask of big picture. Are we moving the needle forward with patients' progress in care? There's a few other from aches and pains, but I'll dive into the second book, The Nerve Root, a few of them, and then we'll kind of dive into graded exposure and then go on from there. So from his second book, The Nerve Root, he mentioned, one of the quotes was, the common low lumbar and low cervical nerve root presentations have a lengthy natural history. Believing there's a quick and instantaneous cure is verging on myth and misleading to patients who are often very anxious. A lot of these, either from the Nerve Root or the other books, he really goes back to natural history. And we've discussed natural history a lot in other podcasts. Other guests have talked about it as well. And I think people can be put off when natural history is discussed because people can assume it means that that's all the information we're providing. Like, oh, this is going to be better regardless of what we do. Maybe sometimes that is the case, or that's like what patients are perceiving. But I think what Louis does really well in the way he describes it in his book is like, yes, a lot of times these things are going to resolve maybe regardless of what we do, but that doesn't mean that we're not overlapping that education and reassurance with other types of treatment, with exploring different movements, trying different exercises, doing different activities that kind of expose them to the things or thing that they are hesitant about, that is provoking their symptoms, whatever it is. It's not just like, yeah, this is going to improve, whether it's a good natural history and it's going to take like a few days or a few weeks, or if it's something like, nerve root discomfort and a radiculopathy that may take a year. It's still using these other contexts of the patient's life and what matters to them, and still working through exploration of movement and rehab, and not just saying like, this is going to get better at some point regardless. So I think that was like a very fundamental thing that he kept going back to. Like, a lot of these musculoskeletal things, they do improve regardless of how long it takes and potentially regardless of what we do. But we as providers are doing more than just explaining that. You have anything to add there?
I think frozen shoulder is a good example of this, where we can educate somebody to say, this is going to take a really long time, but we're not leaving those patients on an island. We're still letting them know that regaining full function probably does require some exercise and some work on their end, and we can help guide that work. And I always see natural history, regression to the mean, yada yada, as empowering. And I can see how it can be viewed as something negative, because oftentimes it's this idea of addition by subtraction, right? Like the concepts of natural history, regression to the mean, etc., mean that oftentimes we're removing things from treatment. But to me as a patient, I would find that empowering to go, oh, I don't need to see you 3 times a week to improve my shoulder. That's great. That saves me time. That saves me money. Oh, I don't need to buy that fancy gadget that I saw come up on my Instagram feed that's $200 to massage my shoulder. That's great. I don't need this surgery. I don't need to overly worry. Yes, I'm frustrated. Yes, I'm stressed. Yes, I want my shoulder to get better, but I don't have to be maybe as anxious or as concerned because you've told me that it's going to get better in a year and a half or 2 years versus telling me it's going to be better tomorrow. And I'm still dealing with this week after week, month after month, year after year.
And sometimes this, I want to bring it back to a remote consult I had a few days ago, but sometimes it's hard to accept that as a patient as well. And it may not change anything in the moment. Like they're still having symptoms. It's still going to take a while. I had a remote consult a few days ago with a individual who was trying to search for the answer on what I believe is kind of a sciatica presentation, and more so radicular pain. And he wants this kind of instantaneous fix. And it's been 4 months and it's very like positionally irritated and walking feels really good. And I was trying to piece together like, what can we take advantage of and do during this potential next few or multiple months where these symptoms may continue, and provide optimism. And these are things we can do. But I want to set this expectation that you're searching for the specific answer and we may not have one to get you better in a week. And that's also just like can be hard to digest as a patient who may be expecting that, but not lying to them and being realistic and honest, I think is what should be done. The last book, I'll mention one quote and then we'll move on to the next episode. This was Graded Exposure, his third book. So far as Graded Exposure and my pain patients are concerned, it's all about return to physical confidence, whether the problem is acute or chronic. The fundamental thing is a process of gradual physical challenge. The patient starts off with movements they find achievable and safe, and then gradually increases the quality, quantity, and difficulty of movement in a slow and progressive way. As I said before, I help do the inventing with the patient, and the patient makes the choices of how and where they'd be happy to go. I think him explaining kind of the base, simple explanation of graded exposure, a lot of times it's not as easy as that. And there's a lot of fluctuations along the way and experimentation. But the zooming out, understanding that it is this process of like kind of poking into pain and symptoms and things that they're movements that they're fearful of or that they've had prior episodes of injury or whatever it is this slow progression back to normalcy or back to their end goal over time. And then I really like the second half of that quote of, I help do the inventing with the patient and the patient makes the choices of how and where they'd be happy to go. So you're not forcing them along this path or like inherently leading them the whole time. You're with them, kind of guiding them, and you provide options and experiments, and ultimately they get to pick and choose and reflect and see how things feel in their body and feel more and more autonomous over their process moving forward. So by the end of it, they feel like they have more and more control. Maybe they don't have full resolution of symptoms and there's still things going on, but they now kind of understand what are these moving pieces that I can adjust and these levers I can pull on my own. I'll stop it there. There's definitely other quotes. Any other like final thoughts with Louis Gifford or that reactive podcast before we dive into the next one, Mark?
I'm going to read one more quote because I was looking through the quotes that you have kind of screenshotted here. Stop the habit of constantly asking about the patient's pain. If it's any help, once I realized I was asking too much about pain, I reckon it took me a good few months to get out of the habit. If you talk about the patient, If you talk about it, the patients will think about it more. You'll train them to maladaptively centralize their pain if you're not careful. All I have to say is kind of what we talked about, is that you don't need to constantly ask about pain, try to fix pain. A big point of maybe contention in our podcast episode that we recorded together was this idea that it's influencing prognosis or predicting prognosis, changing pain in the short term. And we go into great detail about all of the issues with, making that the assumption. So definitely recommend going back and listening to that episode.
And buying Louis Gifford's books. Episode 144, rotator cuff related shoulder pain with Jared Powell. We had Jared on really early in the podcast episodes. He came back to discuss a few of his more recent pieces. If you want to read those pieces, again, go back to episode 144. We've linked them below. There is one or two qualitative pieces on patients' kind of experiences with rotator cuff related shoulder pain. And then kind of this, I think it was more of a narrative review that he wrote, I think with one or two authors, on what is the current landscape of rotator cuff related shoulder pain, mainly from an exercise perspective. And really this episode, I think if you were to listen to the whole piece, there is still a lot of uncertainty and unknowns, like a lot of areas of musculoskeletal rehab, but understanding that we can't really hang our hat on exercise always being an extremely powerful intervention that 100% of the time is going to improve patients' rotator cuff related shoulder pain. It has these, I think he mentioned, kind of small to moderate effects, but one, from a general health standpoint, they should be exercising. Two, based on their whole, life and listening to them, how can we make this exercise or movements of the shoulder meaningful, impactful to them, and bring it more towards the patient in front of you, and using kind of this patient-centered model to still load the shoulder and guide them through the process, but also as a clinician realize that this doesn't have profound effects that we maybe used to think exercise did. A lot of these other treatments are kind of in a similar boat. There's not great evidence that any of them substantially move the needle forward. But from an exercise perspective, it's cost effective. There's a variety of ways we can explore movement, and there's not one specific group of exercises for the shoulder that we need to do with these patients. Jared had mentioned in the episode, I think it was a Chris Littlewood piece, where they studied patients with rotator cuff related shoulder pain. They literally just did one exercise that was in the position in like the shoulder plane of motion that was aggravating to them. And that was the only like exercise that they did. And they still had, I think, positive outcomes and symptoms and function by the end of that paper. So he had mentioned that, just noting that even if you did one exercise, even if it was kind of pain provoking, that still by the end of that trial was beneficial for those individuals. So I think by the end of the piece, the end of the podcast, it just opens up options for providers. And sometimes that feels like there's anxiety of, I don't know where to go. But similar to like the low back pain landscape, we don't have one specific thing. And sometimes this, again, improves with time. It may take longer, but we can experiment with a variety of different activities and options. I also liked this quote that Jared had. I think it was towards the end, but he said, quote, "So this hits on a point where I am sympathetic to a fully pluralistic approach to care, meaning that I'm okay for a physio to be completely exercise-based. I'm okay for a physio to be completely manual therapy-based, dry needling-based, education-based, whatever it may be, as long as they declare it up front. They say, this is my bias. This is how I treat. Do you want to engage in a therapy program with me, given this is how I treat?" And that could be one from treating rotator cuff related shoulder pain, but more generally, like, I think all of us as providers have some bias of where we tend to go from a treatment algorithm perspective and the intervention. And it was interesting to hear him say that, like, he's okay with that with a variety of providers, and letting patients know that up front and being honest about that. And then ultimately the patient's the one making the decision of, okay, I've kind of like laid out my hand and you can see what the options I'm providing or I would provide to you. Is this something that you want to engage and move forward with or not? And it is that kind of ultimate decision-making and consent process. So I really liked that towards the end of the conversation, not just from a rotator cuff pathology or pain perspective, but just in general, like going through this initial examination and treatment with patients, being upfront about what you could offer and what your kind of biases are of what you would do. And if they're not interested or they don't believe it would be helpful, or if they've tried that in the past, then it's okay for them to say no. So I'll stop there. Mark, do you have any kind of follow up with any of that?
I think that's been one big benefit of social media, and not just for us, but for other physical therapists. And, I guess our online presence is that patients can screen who they want to see. If they hear that you don't do dry needling, Chris, and they really want dry needling, then you're not the person that they're going to see. And I think that's fine. That's probably great. They're going to mesh better with somebody who has the same maybe beliefs and values, etc. I will say too, always coming back to education, I don't know how often patients are using the term rotator cuff related shoulder pain, or doctors are using the term with referrals to physical therapists. But education is important here, because let's say somebody has the diagnosis of shoulder impingement. Then we can have a conversation about what that means. Does it mean, we know the qualitative research, patients go, what's physical therapy going to do? I have this certain bony anatomy that's rubbing and tearing things. And now we can have a conversation about, well, maybe that's not actually happening, and this is what we can do. Or a slap tear. Hey, these things are actually common even in individuals who are asymptomatic. Or even a rotator cuff tear. Patients are worried, am I going to make this worse? Is this going to ruin my shoulder? And we know that no, exercise is fine. Some tears don't progress. So knowing all of this different information can help throughout this process.
Let's go into rotator cuff repair rehab. So people that have decided to go the surgical route for rotator cuff tear. This conversation was with Terrence Scroy, who I found out about his work through one of my colleagues, Kevin McNamara, in the clinic. We had a month of discussing kind of acute, early and mid-stage rotator cuff repair rehab. And we used his piece, I think it was Scroy et al. In 2018 or 2019, where him and a few authors gave a framework of some considerations to progress with these rotator cuff repairs early on. And Terrence is based out of the Northeast. I think he's definitely in New York. I forgot which specific hospital, but he pretty much only works with shoulders and maybe elbows as well. I think the big takeaways and things that I had already gleaned from some of the research he had mentioned in his paper, and what we had discussed in the clinic with some of my coworkers on this topic of being pretty conservative early on with these rotator cuff repairs. If you dive into the evidence on what are the re-tear rates, there's a wide range and there's a lot of factors, and Terrence had mentioned them, but it can go from like 10% all the way up to 90+% re-tear for a rotator cuff repair. And a lot of that is going back to what we discussed with frozen shoulder, but a lot of these comorbidities, high BMI, smoker, did they have a larger tear going into it? What was the kind of quality of the tissues that were being repaired? But knowing potentially how high in certain populations and demographics the re-tear is, being very conservative with these early progressions within the first 4, 6, 8, 10 weeks. And that was something before I had really had these discussions with coworkers and read some of Terrence's work and talked to him on the podcast, that I wouldn't say I was aggressive, but I think in PT school, there was, at least in my program, but other coworkers that I've talked to, there was a little bit like, we were kind of going into a blind, and it was like, okay, you give them a dowel, you give them the pulleys, but there's really no understanding of like, what are these logical steps? How much pain should they be in? And I'd be curious to hear your thoughts, Mark, but Terrence recommended during this early stage, there shouldn't be a ton of persistent symptoms. And a lot of patients, and I've experienced this, but he had mentioned on the podcast, like a lot of patients expect the rotator cuff repair rehab to be extremely painful. And his perspective was it shouldn't be that painful of a process early on. And if it is, then we're probably doing something that's a little bit too much, or they're doing something at home that we don't know about, or that they aren't realizing is just too much load on the repair and on those tissues too early on. And that's helped me a ton. We have a ton of rotator cuff repairs in our caseload in our clinic over the past like 6 to 12 months, and being able to track them and understand, okay, this is maybe a starting point for what we can do at home that's safe and appropriate. And these are the reasons why we don't want to do even simple things like brushing our teeth too early on, because there's actually data that that's a pretty good amount of load on the rotator cuff that you don't realize because it's like an everyday activity. But knowing these early conservative progressions, I've moved less and less from like standing dowel range of motion activities or the pulley, because it just gets like, they pretty much just start making it a super active process on that shoulder. So my own kind of treatment algorithm and view of these early rotator cuffs has been do less, focus on passive range of motion in kind of forward flexion and some external rotation, start with some light iso band work standing, and put them in positions where it's really hard for them to use other strategies or to use those tissues too much too soon. So those were my initial thoughts. And I still feel this way in the clinic, but especially these older adults, especially if they have other comorbidities and ones that really aren't super compliant with the sling and do some stuff outside of the clinic, like it feels like I'm walking on eggshells, because at any moment the symptoms could spike and there could be a concern that they retore. So in the clinic, I still feel like this is one of these populations and one of these surgeries that feels volatile at times, and being a little bit more conservative is my current viewpoint compared to a lot of other procedures or non-operative management, where it's a little bit more like, let's push, still based off tolerance and other things, but this one's a little bit more on the conservative end. You have any thoughts there, Mark?
With regards to the pain, obviously pain is going to be variable between individuals across conditions and surgeries. What I imagine he's getting at is that if the precaution from the surgeon is passive range of motion only, or, you know, passive assisted or active assisted, I'm sorry. The idea is that if it's passive range of motion and the patient is experiencing a lot of pain, you know, you don't want to turn that passive range of motion into active range of motion, right? Where they're engaging the rotator cuff, they're engaging that surgical site or aggravating that surgical site more than what they should at a given time point. That's what I would assume that he's kind of getting at there.
Yep, totally. All right, let's keep chugging away. Episode 146, lumbar spinal stenosis with Jim Eubanks. Go ahead.
I was going to say, do you want to just jump ahead and then...
Yeah.
Because this is a pretty extensive outline that you have here, and if...
Totally.
The listeners like this format, we could
keep going.
Come back to some of these different episodes.
Yeah, we have a lot more that we would try to hit before we get into some of this Stu McGill. Do you want to go all the way to Stu McGill reflections, or go to like episode? Yeah, let's do it. Okay. Let's start with the initial conversation. It was between just me and you, Mark. This was episode 137. For people that are unfamiliar with any of this context, Stu McGill went on Peter Attia a while back, early this year, I think, and had a 3-hour episode on low back pain. And there was a lot of controversy and a lot of pushback. And we discussed our views on what was mentioned in that conversation that Stu had with Peter. Let's initially start with how you feel like that conversation with just the two of us went, Mark. And then we can talk about the two we actually had with Stu.
I thought our conversation went well. I haven't gone back to listen to it at any point, but as far as I remember, I wouldn't change my stance on any of the science or recommendations in that episode.
Yeah, I think I feel the same way. Episode 139, 141, part 1 and part 2, where we brought Stu on. What were your thoughts?
I would do it differently. I thought we were very accommodating with requests. For example, the request to be able to present PowerPoint presentation uninterrupted. And the reason I say that is that I thought we were both being very respectful, even in our initial episode and with this episode, and accommodating and whatnot. And I feel that it's still somewhat backfired. And the reason that I wanted to take this approach is that I gave this example to you shortly before we started this episode, is that it's the same kind of approach you would take with the patient. If a patient comes in and says, hey, my rib is out of place, the first thing you tell them isn't, you're dumb, I disagree with you, your rib isn't out of place. You listen to understand where they're coming from, and then you try to have a conversation with them, whether it's directly during that visit or in the future. But the idea is that you're building this rapport, you're building this alliance, right? We hear it all the time, like therapeutic alliance. And so the idea is, how can we do that same thing with a guest who we maybe have a different viewpoint about things? We don't want to bring somebody on and then just argue, disparage, or have this very confrontational thing. It's, let's try to build this relationship and maybe come to a mutual understanding about things. Because we have had like a, quote unquote debate a long time ago, and that episode didn't necessarily go the way we anticipated. And so it wasn't only important for the episode we did with Stu, but hopefully for future guests that we disagree with, so they feel comfortable to come on and have these types of conversations. Like I said, the reason I might have taken it a little bit differently is that I don't think it necessarily landed the way that we wanted it to land. Stu has very strong, let's say, followers, and they were critical of us regardless of what we said or the nuance that we tried to insert. Similarly, people who wanted to see us push back against some of Stu's claims said, well, you guys just let him talk uninterrupted and kind of lecture you and not disagree with anything. So it kind of fell flat on both standpoints there. Anything you want to add to that? I still have more thoughts, but if you want to add to that.
Yeah. Well, it does and did feel, in a sense, like a lose-lose, because all the things you had mentioned of, we didn't want to go out interrupting Stu every minute. We wanted to be respectful. We had already given an hour and a half of our own thoughts on a prior episode. So it was a little bit of opening up the floor for him to elaborate or to provide correction. But it did just, in a sense, devolve into a PowerPoint presentation. And that's really tough. Yeah, I'll stop there. Keep going with your thoughts.
And I really wanted to, in these conversations online, right, it's always straw mans, attacks, whatever it may be. And I wanted to find common ground with Stu. And I think we did that to a decent extent with, especially that first episode, we were saying, hey, maybe his recommendations aren't as strong as maybe assumed or implied from the Peter RT episode, or maybe as they're broadly applied. But there were still some things, obviously, that we're going to disagree with. And that's why I say everything that I said or recommended on that first episode of just the two of us, my mind didn't change. And there's some things that were just hard to push back on. An example would be, I brought up the prone instability test not being a valid test for assessing true instability of the lumbar spine. And, Stu discussing how he's able to feel these micro movements of the lumbar spine because he's been doing it for a long time, and it's an N of 1 experience. So no amount of research is going to change his mind about that belief that he has. And me just arguing with him or attacking him also isn't going to change his mind. And if anything, it's going to decrease some of that trust that I built.
So what would you have done differently?
I think not doing the PowerPoint presentation would have been helpful. I know that he said that he had prepared it already for some conference or something, but there were like specific things where even my name was on the slide, so it was obvious that it was prepared for our discussion. And I just don't think that it allowed for, what we wanted it to be, which was a discussion. And if we wanted to discuss every point in that Peter Attia podcast, which was a 3-hour podcast, our podcast would have had to been 6 hours or 9 hours probably. But I think, just having a little bit more of a discussion, maybe a little bit more of back and forth, a quote unquote debate about our differences of opinion, I think probably would have been helpful. Just challenging, I guess, a little bit more. And I think if we have other guests on in the future that do have differing opinions, it'd probably be helpful to challenge them on those opinions, and hopefully they challenge us on our opinions. That's my thought. What about you? What did you think of the whole conversation?
Yeah, to what you had said about the first episode, I think that one was a little bit more eye-opening, that we could meet in the middle on a good amount of things. And then he had pulled back on some of the statements he had made in the conversation he had with Peter Attia. I think he used the excuse of Peter was asking him questions on the spot, and that's why he wanted to. He regrets some of what he said, but Stu's also, I think, in his 60s, and he's been doing this for decades. So if you're being asked to come on a podcast on the topic that you're an expert in, and you're being asked something on the spot, just with how off some of the statements were, and him kind of pulling it back and readjusting with what he was saying to us for some of the things, that just feels weird that had to occur for someone that has been teaching and researching and doing this for decades. So I'm just a little bit skeptical as to where Stu's true kind of views are when he has to pull it back so abruptly when he is getting pushback. So overall, I don't know what the best format would have been. Like, obviously the PowerPoint wasn't the best idea. Do you think, Mark, like for this episode with Stu, or the potential debates or discussions moving forward, we set that expectation that maybe we do like a timed, like this is the 3 to 5 minutes you have for this specific question or topic. We'll stop, we'll provide our counterpoint, almost like a true debate format where it's a little bit kind of sterile, but it creates these constraints. Do you think that would have been helpful with Stu?
I don't know. I don't know if you watched any clips of our recent presidential debate. So I don't know if muting microphones and a time limit is the thing to do. I just think that, we probably have to have a little bit more of a back and forth discussion. And like you said, I understand misspeaking. Like I just misspoke on this episode where I said passive assisted instead of active assisted, but I would never make the claim that smoking is good for your health, right? Like, so.
Yeah, I hear you. Do you think these conversations overall are beneficial? Like if you're picturing yourself as like new grad Mark or student Mark, and you were listening to the conversation with Stu, and maybe you didn't know one way or another, and you were just listening, and maybe it's hard to put yourself back in that person's shoes. Or if we do more episodes like this with other individuals, do you feel like it is productive, or is it just like clickbait?
I'd like for it to be productive. And our intention was for it to be productive. And I just made a joke about our presidential debate, but it's like that, right? We have these tribes where if you like Biden, you like Biden no matter what. If you like Trump, you like Trump no matter what. And so with our conversation, it was, hey, if you liked Stu, you liked Stu no matter what. If you dislike Stu, maybe you dislike Stu no matter what, rather than listening to learn and critically think and think through the nuances. It's just either for both of us, right or wrong. And there's just so much more gray area. And that's what I want people to take away from this. And what I wanted them to take away from that episode is that there's a lot of things that we do know about lumbar spine and lifting and whatever else. And maybe we have to accept some of that gray area. Maybe some of the gray area is where we disagree. But I would hope that that gray area is only like a 5% disagreement, right? Like we agree on 95% of things, but it's really just that small margin that we disagree on. That would be my hope and intention. And that's, I think, where the learning comes from. And, I taught at USC for several years, and that's always a conversation that I would have with students, is that I'm not always going to have the answers. And it might be a little bit frustrating to hear that, but kind of accepting that gray area, that uncertainty, is a lot of the times where the learning and critical thinking is going to happen. That metacognition, right? You're thinking about your thinking, you're thinking about why you're thinking what you're thinking. Yeah. So I was hoping it would be productive. I don't know if listeners thought it was productive.
Yeah. Let's call it there, Mark. So if anyone finds this conversation valuable and likes these summary recap episodes, let us know. And if you do, great, we can do more of them. And if not, that's okay. We're experimenting with it. Any final thoughts, Mark, before we call it?
If you're not subscribed to us on YouTube, subscribe to us on YouTube. Check it out. That's all I got.
Perfect. All right. We'll call it there. Thank you, sir. Have a good one.